Coming to the last last part of the topic, which is antiphospholipid antibodies and pregnancy. So this is basically what is antiphospholipid syndrome. There is a newer criteria. I will not be going into it. Just to simplify things, the laboratory criteria consists of three things, which is lupus anticoagulant, cardiolipin, and beta-2 glycoprotein. In combination with this, the patient clinical manifestations can be commonly one of two, which is either a thrombotic event or a pregnancy-related morbidity. So we classify it as obstetric APS or thrombotic APS. Thrombosis, as we understand, can be arterial, venous, small vessel. Pregnancy-related morbidity, I am pretty sure we all know here, is basically unexplained 3 miscarriages less than 10 weeks, unexplained miscarriages greater than 10 weeks, even 1, and a premature delivery due to before 34 weeks due to placental insufficiency or preeclampsia. Now, the APL, the antiphospholipids can affect pregnancy in various ways, both maternal and fetal, which can be miscarriages, fetal loss, prematurity, stillbirth. And on the maternal side, it can cause thrombotic events, nephropathy, migraine, CNS effects, skin rashes like livedoracemosis and racemosa, and even valvular heart disease. Now, this is basically, I just highlight in brief. I had actually wanted to put this slide in the SLE part of it. The contraception is an important part. What we need to basically consider is, in patients with antiphospholipid antibodies or SLE, estrogen containing contraceptive devices or methods should be generally avoided. So either an IUDs or a progesterone only pill should be considered. Any estrogen containing thing should absolutely be avoided because of the prothrombotic risk of estrogen. Okay, fine. So practical tips on antiphospholipid syndrome. One of the common problems, common practices we see is that people order the test called antiphospholipid IgG and IgM. Now, this is a test which is not validated. So, antiphospholipid IgG and IgM as such should not be done. This is the 2025 ISHT guidelines, which basically tests, these are the 3 tests to be done: lupus anticoagulant, anticardiolipin, IgG and IgM, and beta-2 glycoprotein 1, IgG and IgM. These are the 3 tests. If we are wanting to do these tests, please specifically write 3 in separate. Otherwise, labs usually end up doing antiphospholipid IgG and IgM, and they are poorly validated. They may be positive or negative without any consequence. You should ask for a prior history of thrombosis, because if present, patients may need therapeutic anticoagulation, and a risk classification and management is required. Now, risk profiling is basically based on antibodies. We classify it as high risk and low risk. Now, high risk is triple positivity or dual positivity or an isolated lac positivity, lupus anticoagulant. So any of this is considered as a high risk. Low risk would be isolated anticardiolipin or an isolated beta-2 glycoprotein 1, especially if they are low titers, transient, or an IgM subtype. So risk profiling is important when it comes to management. So this is my last slide, which is how we manage. So the first scenario is an asymptomatic patient with antiphospholipid antibodies positive. Now the patient may have been tested for any reason. They might have undergone a test. She is positive for this with no symptoms whatsoever. Or she may be a case of SLE in which we routinely test. She may be positive with, again, no thrombotic and no obstetric history. How do we go about it? Now again, we classify it low risk or high risk, as I already told. Both these patients, aspirin should be given. So if an asymptomatic patient mother is there, low dose aspirin is required. Second thing is obstetric APS. So suppose there is a risk of recurrent miscarriages. How do we go about it? First thing is, preconceptionally, patient should be started on low dose aspirin, 75 to 100 milligrams of aspirin. And after pregnancy confirmation, we should give low molecular weight heparin or unfractionated heparin at a prophylactic dose, which is usually enoxaparin 40 mg once a day. If these do not work, or if despite on these patients have recurrent abortion, then there are other things like adding HCQ, increase to therapeutic dose heparin, or a low dose prednisolone. I personally, you add hydroxychloroquine upfront to these patients because it's generally safe and there are not much of side effects, and it is proven to be beneficial in the whole pathogenic mechanism of antiphospholipid syndrome. So what I generally do is aspirin, low molecular weight heparin, and hydroxychloroquine. Postpartum, the aspirin and heparin should be continued for 6 weeks because the thrombotic, the risk persists for up to 6 weeks postpartum. And the last part, which is thrombotic APS, if the patient has had any stroke, DVT, CVT, any thrombotic event in the past, they need therapeutic anticoagulation, which means a BD dose of enoxaparin. This is another common mistake that we see. Patients are given once a day heparin, which is inadequate, and in pregnancy the risk is again high. So twice a day heparin, which is 1 mg per kg given twice a day of enoxaparin or a heparin in adequate doses should be required, along with low dose aspirin. Warfarin to be avoided throughout pregnancy. Postpartum, warfarin can be restarted instead of heparin depending on the patient preferences. So that concludes my talk. Thank you so much.